My name is Felicia Prasad, and I present a case of catecholamine excess from an unlikely entity, a paraganglioma. Paragangliomas are rare neuroendocrine tumors that arise from paraganglionic cells. These chemoreceptor cells are further derived from mesodermal and neural elements originating from the neural crest ectoderm and are most commonly found in the carotid or vagal bodies of the head and neck. Very rarely, paragangliomas can be functional, and patients can present with hypertension and palpitations due to the overproduction of catecholamines. A 66-year-old female with a past medical history significant for hypertension, hyperlipidemia, obesity, hypothyroidism, and an unknown left-sided carotid mass presented to the emergency department with 2 days of worsening retrosternal chest pain that radiated to the left neck with associated palpitations and shortness of breath. On physical exam, the patient did not appear to be in any acute distress, but was found to have an irregular heart rhythm consistent with new onset atrial fibrillation with a rapid ventricular rate of 157 beats per minute. Her initial blood pressure was elevated at 242 over 105 with evidence of end organ damage with an elevated creatinine of 1.26. The patient was treated with aspirin 325 milligrams, diltiazem 50 milligrams, with mild initial improvement of her heart rate and subsequent transition to a continuous infusion of diltiazem and a heparin infusion for anticoagulation due to her increased risk of thrombotic events. Within a few hours, the patient converted from atrial fibrillation to ventricular tachycardia with hemodynamic instability, for which she received synchronized cardioversion at 100 joules, which aborted the dysrhythmia. Due to the new onset atrial fibrillation, ventricular tachycardia, and hypertensive emergency, and the possibility of the carotid mass leading to these symptoms, a CAT scan of the neck was done, which showed a 2.2 by 1.9 by 2.9 centimeter mass at the carotid bulb encompassing both the left internal and external carotid arteries. Vascular surgery was consulted, and the patient underwent successful resection of the tumor with biopsy confirmation of a paraganglioma. The hospital course was complicated by resistant hypertension, which required titration of multiple antihypertensives prior to the surgical resection of the tumor. The patient was subsequently discharged home on a regimen of hydralazine, prazosin, valsartan, spironolactone, and apixaban. She was scheduled to follow up with nephrology, as well as to have a positive electron tomography scan to evaluate for additional tumors throughout the body. In Figure 1, we see the black arrows showing the tumor on the CAT scan of the neck. In Figure 2, we see a specimen of the paraganglioma that was resected. Extraadrenal paragangliomas that occur in the head and neck are very rarely functional. The prevalence of a paraganglioma associated with hypertension, such as this one, is about 0.05 to 0.1%, and although rare, can have serious consequences if not diagnosed and treated in a timely fashion. While initial workup involves biochemical diagnosis of metanephrines and catecholamines, it is still important to note that these are not always present and should not prevent additional imaging or evaluation. In most cases, surgical resection of the tumor is curative. However, patient selection should be carefully considered prior to recommending aggressive surgery, as it too is associated with significant morbidity.